Come on in, take your seats if you will, please. We're about to start. Welcome and good morning to our session on sciatica. We have Mr. Martin Wilby, who's going to talk about his nerves trial and the state of play in terms of surgery and nerve root injections. But first to kick off is Anina Schmidt, who will present some very thought-provoking work on neuropathic pain and sciatica. Thank you, Anina.
Wonderful. Well, thank you very much for having me, and thank you for all of you for coming at 8:30 in the morning, so that is really great. So talking about sciatica and neuropathic pain, I was thinking, in 20 or so minutes, that's quite a big topic. So what should I talk about? And maybe I want to be a bit thought-provoking in terms of talking about making a case for heterogeneity, because maybe I think that is where the roadblock is at the moment in us making advances in that space. These are my disclosures. Now, as you know, sciatica is a very common condition, and sadly about 30% of patients develop persistent pain and disability. The first-line treatments for sciatica is pharmacology and physiotherapy. And I give you the most depressing slide first so that we are over and done with in this talk, and that is the systematic review evidence for pharmacology in patients with sciatica. And as you can see, no matter which drugs we are giving, whether this is non-steroidals, oral steroidals, antineuropathics, they are not actually any better than placebo in a population of patients with sciatica. Now just brace yourself, because if you're a physiotherapist, this slide is unfortunately even more depressing. This is a systematic review done by my very talented colleague Lucy, and she looked at physiotherapeutic interventions for patients with sciatica. And if we compare them to more substantial interventions like injections or surgery, but even if we compare them to basically doing nothing or a placebo intervention, they are not any better, really. And maybe there's a small, tiny effect for physiotherapy in the long term, but effects are really small. Now, of course, we can say, it's high risk of bias of studies, and of course, a lot of these studies don't use, contemporary physiotherapy as what we think we should do nowadays. Fair enough. But that is what the evidence at the moment tells us in terms of our first-line interventions. So what are the reasons for that? First of all, we could just say treatments are not effective, full stop. We can now think about other types of interventions. Or maybe another reason could be that there is heterogeneity in sciatica. And by lumping this wide group of patients with sciatica together, it could be that we are missing and diluting potential effects that might happen only in some of these patients. And that is the case that I would like to make today. But as I said, I will probably raise more questions than answers for you today. Now, this heterogeneity of sciatica is very clear already when we look in clinical trials and how do they diagnose or include patients with sciatica. Some rely on symptom distribution, but as you can see, we cannot even agree where exactly should be the symptom distribution in sciatica. Some say to the buttock is enough, some say it has to radiate to the knee, and some say it has to go all the way to the foot or pain below the knee. Others then use signs such as imaging, nerve mechanosensitivity like straight leg raise or neurological testing, and many of them use a combination. So of course, these are quite different populations potentially, and this is what I would like to make a case to you today. So what I will do is I will go through 4 diagnostic criteria that are commonly used and ask the question, what do they actually show? Are they actually diagnostic of sciatica? And can they give us potentially any clue of a patient population that might react differently to treatment? As I said, I will probably raise more questions than giving answers, but maybe that is the state where we are at in the moment in the sciatica research field, that we really have to go back to the drawing board and think a bit and do a bit of soul searching. Now, first of all, the criterion of pain distribution. And of course, a lot of studies just use pain below the knee. And that comes from, historical studies where they do intramuscular or somatic tissue injections with hypertonic saline, which then creates referred pain from somatic structures. And indeed, if you see here, facet joint injections clearly radiate mainly to around the buttock area. But then look at that. If you inject a multifidus muscle, it actually radiates all the way to the knee. And if you do an injection in an interspinal ligament, radiation pain from those structures can radiate all the way down to the foot. So clearly, by just saying the pain has to radiate below the knee doesn't necessarily mean that we purely include patients who have a nerve problem as such. And then is the story, of course, with the dermatomes, where we say, yeah, it has to be a dermatomal distribution. But we all know that if we look at patients where we are certain that they have lumbar radicular pain, for example, in this study, L5, you can see that they found that about 2/3 of patients have symptom patterns that were well beyond the dermatomal distribution territories. Now, what can explain that neurobiologically? One explanation could be inflammation. And indeed, when we work in animal studies trying to understand how nerves react to impacts, in this case, chronic nerve compression, we do find inflammation not only at the lesion site, but we find it remotely. For example, in the dorsal root ganglia, here with activation of satellite glial cells on the right, dorsal root ganglia that receives input from a compressed nerve, activation of macrophages and activation of T lymphocytes. But quite intriguingly, we do not only find that inflammation at the level of the dorsal root ganglia, but people have also reported that this happens at the level of the spinal cord, which of course is very far away from that nerve root or that peripheral nerve. And here you can see a nice activation of microglia at the level of the dorsal, but also ventral horn. Now, we do know that if neurons lie in this inflammatory environment, they will lower the firing threshold and become hyperexcitable. If that happens in nociceptors and these signals reach the brain, that might well be interpreted as pain. And we also know that at the level of the spinal cord, nerve fibers, before they exit through dorsal root ganglia segmentally, they will have connections at multiple levels. So of course that can explain why if you have an inflammation at the level of the spinal cord, you could get multisegmental hyperexcitability leading to widespread pain. Now, this is animal work, so does that actually happen in humans? Now, this is quite an interesting study done by Marco Loccia's team at Harvard University, and they used simultaneous PET scanning and MR imaging. And in the PET scan, they used a ligand that binds to glial cells. And maybe not so surprisingly, they found that in patients with lumbar radicular pain, L5, there was this uptake of this marker in the neuroforamina, so a local inflammation. But much more intriguingly, they also found that there was this uptake of that marker at the lumbar level L5, which is, of course, at the lumbar-thoracic junction, so far away from where that compression site is of the nerve root. Now, intriguingly in their study, and arguably these are small numbers, but they asked a question, does that correlate or is that associated with a response to steroid injections? Now, even though these are very small numbers, because PET is radioactive and incredibly expensive, and you're not just doing that in all patients who have a sciatica, if not for research. But what they found is if they grouped the patients who had a good outcome to an epidural steroid injection versus the ones that did not benefit from it, you can clearly see that the ones that had a benefit from it were the ones that actually had inflammation locally. And that would, of course, neurobiologically make sense. But the question is, again, how can we pick these patients that have more of an inflammatory phenotype? Because clearly, as you can see, not all patients have that inflammatory phenotype. Now let's come to the second point, and that is magnetic resonance imaging. And I don't have to tell you that, these are great for many things, but they of course have a lot of false positive, but equally as many false negatives as well. The main problem, though, that we have with imaging is that it doesn't correlate with pain or disability, and that is very clear already since a long time. This is a study from Karpinen, very nicely showing that disc-related changes do not have very much association with pain or disability. But really, when we think in neurobiology, we know very clearly that nothing has to encroach or directly deform a nerve to actually affect a nerve. And we know that from very simple examples like carpal tunnel syndrome that you can see here. If we do an MRI in these patients, there is nothing that mechanically deforms that nerve. And yet these patients have a very clear diagnosed nerve problem. One explanation for that is, of course, that there is increased pressure in the tissue that is acting on the nerve. And we know that because we put an epidural needle into the tunnel and we measure the pressure inside the tunnel. And we can see that these patients have a higher pressure than healthy people, and that pressure increases if they move to end range extension or flexion. So we cannot image with T1 and T2 sequences this heightened pressure in the tissue. That is not possible, but that doesn't mean it's not there. Now, in the spine, that is a bit more tricky because quite often you have to do a laminectomy to actually do those pressure measurements, which will then already change the pressure measurements. But there are some studies that have attempted to do that, especially coming from Japan here, in patients with lumbar spinal stenosis. And they also find what we would expect, that if you increase, if you go into flexion, the pressure levels decrease. If you go into extension, the pressure levels increase. And of course, in clinics, we often see that almost kind of ischemic pattern of nerve problems quite often, also in sciatica patients. And the question really is, do we have to treat them the same way as, for example, those with a proper neurological structural deficit? So tissue pressure could be something that we certainly cannot image, but it could also be that there are intraneural changes that we just simply cannot pick up on normal T1 or T2 images. And there is a lot of new methodologies that have come up in the imaging field. One of them that has gained a bit of traction is diffusion tensor imaging, which basically is a microstructural method that looks at diffusion of water protons in tissues. And the theory is that if you have a normal nerve with good myelin, water protons in the nerve should diffuse directionally along the axis of the nerve. However, if you have demyelination or inflammation and swelling, then the water protons have more access to space and therefore will diffuse more randomly, so less directionally. That is the theory of what diffusion tensor imaging tries to show. So it's a microstructural imaging sequence, not macrostructure. And again, we have used proof of concept in carpal tunnel syndrome. On the left side, a normal T2 image, and then the FA map, so the anisotropy map, the directionality map. And what we find is very clearly in patients with carpal tunnel syndrome, we can find reduced fractional anisotropy, so that means more random movement of water. What was, however, quite intriguing is that this measurement strongly correlated with patient symptoms. So the more random water movement there was, the more abnormal the diffusion imaging, the more symptoms these patients had. And that is intriguing because, of course, that is what our macrostructural MRI cannot tell us at the moment. And we are not the only ones showing that in carpal tunnel syndrome, but this is data from patients with lumbar radicular pain, and again showing that this fractional anisotropy value on diffusion imaging is strongly correlated with the Roland-Morris Disability Questionnaire. There's this study that came out a couple of years ago where they then looked at patients who have clinical symptoms of sciatica, but when you image them with routine imaging, you cannot find anything. And then they did the diffusion imaging, and what they found is that these patients had, again, reduced fractional anisotropy on the painful side in the nerve roots as compared to the pain-free side, and also as compared to healthy participants. And they suggested that diffusion imaging might be much more sensitive than picking up nerve changes than the routine MRI would be. And then came this study, which looked at 117 patients with lumbar disc herniation. They all had surgery, and they grouped them into those with favorable outcome versus unfavorable outcome. And they looked what predicted that favorable outcome. And it was younger age, it was shorter disease duration, and notably again, it was the microstructural finding on the diffusion imaging. And specifically, it was fractional anisotropy who was highly discriminatory, meaning that those patients who actually had a more normal microstructure, so still a more preserved nerve biology, were the ones that had a better outcome after surgery. And again, you know, if you think about that, it of course makes sense neurobiologically, because if you already have changes in the structure of your nerves, potentially the prognosis might be either longer or a bit more difficult. So really the question is, could we use this methodology to understand a bit better what patients are reacting to what? And at the moment we are running a large forecast study, which is a prognostic study looking at patients with acute sciatica, and we are following them over 1 year, and we are determining which patients develop persistent pains and which people recover spontaneously. And we use quite a comprehensive profiling of somatosensory, psychosocial profiling, proteomics, metabolomics, but also diffusion imaging amongst other advanced imaging sequences. And hopefully in a few years I might be able to tell you whether or not these sequences, for instance, can tell us a bit more about why and which patients do not do well. Now, let's get to the third point here, and that is the neurological examination. And I'm pretty sure all of you know, if we look at patients with sciatica, sometimes we do find a neurological deficit, but quite often there is no neurological deficit. In fact, in the forecast study, and this is just preliminary data from the first 100 or so patients, where we show that it's about 30% of patients who have a sensory deficit or a reflex deficit, and only about 15% of these patients recruited in primary care have an actual observed strength deficit. Now, this is quite intriguing because if you actually listen to patients, quite a lot of patients will tell you they feel weakness in the leg. And this is what Lucy Duff in my team became quite interested when observing that in her clinic. So she did a review of her, a retrospective review of her data collected in the Oxford Spinal Triage team. And she compared what does the observed weakness tell us compared to what do patients tell us in terms of weakness. And here is the data. This is measured objectively, observed weakness on the MRC scale, with 5 being normal strength and 0 being no activation of the muscle anymore. And you can see most patients actually had really quite preserved strength. However, if you look at reported weakness with the sciatica bothersomness index, the scale here is to the other side, so 6 meaning they actually have substantial bothersomeness in weakness, and 0 is there is no weakness that bothers them. You can see that actually a lot of patients do have reported weakness. And Lucy then asked, what explains that discrepancy of reported versus observed weakness? And she found in the model that age, so increased age and increased leg pain severity, which again, neurobiologically probably would make sense, does explain this discrepancy. But again, it raises the question, can we just treat all these patients exactly the same way, whether or not they have a neurological deficit, whether or not they have an observed neurological deficit, or a deficit that is more reported and might be associated with other factors rather than a true neurological deficit? So these are all questions that I think remain really quite open. Now, as a last point, before I will then give it to you to try and come up with solutions, is the fact that if we see patients with sciatica, even though we think it's a nerve problem, not all these patients actually have neuropathic pain. And again, this is preliminary data from our forecast study using a screening questionnaire, and we can also look at that in different ways. But in fact, in our cohort, primary care, only about 26% of patients have neuropathic pain. So if we then think again, to the most depressing slide that I showed you, where we say neuropathic pain medications are not better than placebo in patients with sciatica, it really raises the question, well, what kind of patients did they really include in these studies, if actually a minority of patients have frank neuropathic pain? And this is a question that Jenny, who is doing an NHR predoctoral fellowship with our team, was answering by doing a systematic review. And she looked at all trials that use neuropathic pain medication for low back pain and or sciatica. And what she found is, I would say, quite sobering, and some of you might have seen her talk yesterday, but of the 25 RCTs, 36% actually included patients that we would classify as unlikely to have neuropathic pain. In fact, they even excluded patients who had neuropathic pain from those trials. 24%, we have no idea what exactly they included, and only in 16% of these trials, we would class them as having a diagnosis of definite neuropathic pain. So really, can we then tell whether or not these drugs are effective? Now, Jenny has done a lot of meta-analyses as well, and I would like to show you just the one result, asking the question whether there is differential effects on neuropathic pain, whether or not trials actually included patients who have neuropathic pain. And this is the data in the meta-analysis, and as you can see here, neuropathic pain drugs are no better than placebo if we give them to patients who are unlikely or unclear to have neuropathic pain. However, if trials included patients who had possible, probable, or definite neuropathic pain, there is a signal here suggesting that neuropathic pain medications were more effective than placebo. Now, have a look though here. The effects are small, so it's a bit above 10 out of a 100-point scale. So this is still probably not perfect, in selecting patients as yet. And of course, this grouping of studies was done retrospectively because, a lot of studies is a bit difficult, how they report, how they included patients and make that decision. But I would argue, seeing this graph, that maybe at the moment we should not just blanketly say we should not give neuropathics to these patients, but maybe we haven't asked the right questions as yet. Is there a specific patient population with sciatica that actually benefits from these medications? And that probably is at the moment the question. Now, in summary, I hope I could show you that there is, of course, no single diagnostic test for sciatica, because all these tests test more something like a mechanism that might or might not be there in different patients with sciatica. So there is massive heterogeneity. And if we think about mechanism-based heterogeneity, we have those with loss of function, we have those with neuropathic pain, we have those with somatic referred pain, and we have those with nerve mechanosensitivity, which I today did not even make a case, but I could make a very strong case why, again, these are very different. But also we have those with a more ischemic versus a more inflammatory pattern, etc. And the question really is whether this heterogeneity is responsible for the really quite weak evidence that we have at the moment in the field of sciatica. And whether the key to understanding sciatica and improve management really is for us to take a step back and think a bit more about what is that heterogeneity in these patients. And is there something that could give us clue on how we could stratify patients better? Yeah. And with that, I would like to thank very much my team, who has created a lot of this work, and also the forecast team, who is currently running at full speed with our prognostic trial. Thank you very much.
We're going to move straight into Martin's talk now, and hopefully we'll have some time at the end to quiz our guests. Thank you, Anina.
Well, thank you very much, Mr. Chairman, ladies and gentlemen, for the opportunity to share with you some clinical data about how to treat these patients. As we've heard, these are complex patients and probably a bit of a mixed bag in terms of methodologies and pathogenesis. So we're going to go through the literature, and I'm Martin Wilby, working at Liverpool. Just a disclosure, this was NHS-funded research. And before we go any further, I just want to say the levels of scrutiny, research governance that exist for NHS research trials in the UK is very stringent, so this is believable research. So when you're trying to read a paper and try and judge it on its merits, anything with this NHS, NHR stamp, I think take very seriously. Okay, so I also want to make a disclaimer. There are certain conditions where we think surgery is a clear winner in terms of how to treat sciatica. And very briefly, those are an acute foot drop or cord-requiring syndrome. Now, we're not going to get into those topics today, but obviously there are a number of causes for L5 weakness. But generally, if a foot drop was to present in an acute situation, those would channel down more of a surgical road. So look, I don't need to tell this audience these facts. We all know it's common, and we heard about how common myelopathy was. But look, this is really much more common than that. And you know, this is all obviously the data that we try and sell the research idea to the funding body. This is to say this is a real problem. So, you know, at any one time, more than 10% of the population is suffering from this condition. And we know that it's disabling, and anyone who's had it will know that, and it's one of the most common causes for time lost off work. So not only does it impact on individuals' lives from their own personal level, but also impacts on the workforce and the economy. So it has far-reaching effects. What about treatment? Well, I think what struck me at the beginning of this journey that was the formation of nerves as a trial, it struck me as very puzzling why there were so many different ideas in the world. Everyone had an idea about how to treat sciatica. Some were saying this is clearly a surgical problem. Others, this is clearly an injection treatment. And others did a bit of both. So interestingly, if you present in Denmark, you don't get either. You don't get surgery or an injection. You just get supportive reassurance that, look, this is going to get better. So what is the correct treatment? We do know, though, that 70% resolves within 6 weeks, and that's why we've got this kind of arbitrary cutoff before we will recommend an MRI scan in the first 4 to 6 weeks, because the vast majority will get better. Surgery is often considered the gold standard, rightly or wrongly, and I'll try and share with you some of the literature that might suggest that, and you can read for yourself and interpret for yourself what you think at the end. Now, here's a statement from Gordon Waddell. The diagnosis of disc prolapse is overused, misused, and abused by both patients and physicians. And it might seem strange that I, as a surgeon, is saying that, but really, I think we have to, first of all, do no harm to patients. So here's a really good paper, and this chap, Weber, presented his work in around about the early 80s. And he looked at, this is probably the best paper I've come across so far that tries to define the natural history of sciatica. And he looked at 208 patients within 14 days of onset. They were examined religiously. Questionnaires were sent out and completed arduously. And he found that 70% improved within 4 weeks, 60% were back at work. But as we've heard from Professor Schmidt, there are a distinct subgroup of patients that don't get better. And no matter what we do, that seems to be the case. If you look at the first RCT, randomized controlled trial of surgery versus conservative, again, this was delivered by Weber, and he published in Spine in 1982. Straight off the bat, you've got a clear selection bias here. He excluded the clearly surgical cases. What did he mean by that? Well, did he mean the foot drops and the cord recliners? We don't know. Was it just the size of the disc? We don't know. So straight away, there's a selection bias there. He defined conservative care as an additional 6 weeks of physiotherapy. He doesn't say whether he used any epidural steroid injections, but his numbers were good. But look at his outcomes. Very, very simplistic in terms of how he quantified or qualified the success of the treatment as either good, fair, poor, or bad, so reported simply by the patient in those terms. And although he found that 90% of surgical patients had a good outcome, he did show that 60% of conservatively treated patients also had a good outcome. And although this might seem to suggest he's a proponent for surgery, actually the paper is very clearly stating that we should all be not operating on these patients, and he's a very clear proponent for conservative treatment because of look at how good the conservative arm of this study is. Then if you go to bigger groups, and you all know the Atlas study, the main cohort, again, this is not a randomized study, this is a prospective cohort of observational outcomes. But it's big numbers, right? So 275 in the surgical group, conservative 232. Both groups, however, had already received an epidural steroid injection before they were enrolled, right? So a similar number in both groups. So around about a quarter of each group had already had an injection before they got enrolled into this observational cohort. However, they did find a strong result from surgery, so 81% surgically and 56% in the conservative treatment. So again, another strong proponent for non-surgical treatment. Interesting, this group, there was one nerve root injury, and I find that this probably doesn't come across from all these big studies. They don't report it very directly, But in this study, it's quite obvious there was a nerve root injury. If you look at the very, very well-known paper, Sport, Jim Weinstein and Harry Herkovitz from 2014, obviously, as you know, this was a massive cohort of patients. There were two real arms to this study. One was a cohort observational outcome. The other one was a randomized section. So this is the randomized component of it. And again, it's comparing surgery versus usual care. And what was usual care? So it was at least active physical therapy, educational counseling, non-steroidals, and injections. But how many got injections? Well, actually, only about half of the group in the conservative arm got injections. And there was a lot of crossover, and that was one of the big criticisms of this, that a lot of the non-surgical patients crossed over to surgery. But look, they reported this as a favorable result for surgery, but their primary outcome reported no difference, right? But their emphasis is clearly favoring surgery, although their primary outcome showed no difference. Anyway, so if we look at cohort studies of root blocks, that's pretty much the best evidence thus far for showing how successful they are. And there's quite a lot of variation in the literature, but some of the more successful studies support evidence of up to 3/4 of patients improving with these treatments. But again, this is limitation. This is a limited interpretation because these are cohort studies mainly. So again, you can't really interpret them and adapt that to a bigger population. If you look at evidence comparing the two treatments, again, what struck me, there was lots of misconceptions. Everybody said to me when I started this, but everyone's done this, right? Everyone's compared nerve root injections to surgery. They've done it before, haven't they? No, they haven't. This guy had, Butterman, but he is a single practitioner, and he's not comparing the transforaminal route. He did an interlaminar epidural steroid injection, and he compared his own patients to either an injection, so a posterior interlaminar epidural versus surgery. So again, limitations are you can't know, you don't know if that's adaptable to a wider population. It's a single center, single surgeon. So lots of potential areas of bias there. But he found that 50% of patients didn't need surgery if they had the injection first. And he did have good follow-up to 3 years. So he, again, was a proponent for conservative care. And again, anyone who understands trying to set up a trial and trying to work out things like power and statistics, for numbers less than 150, it's unlikely that would have been powered. Okay, so we knew back in 2012, 2014 that no one had done a direct one-to-one comparison of the two best treatments of the time for this very disabling condition. The nerve root injection delivered right to the source of where the pathology is, right close to the nerve and the disc, i.e. transforaminal epidural steroid, or surgery. So no one had done a direct one-for-one comparison. So we proposed that we do that. And we wanted to initially get patients in as quickly as possible. So we wanted to try and keep the window within 6 months, but recruitment issues made us extend that to a year. We obviously didn't want to cause harm to patients and miss foot drops or cord requirements, so we excluded patients with a motor weakness. And again, we want to show that this is cost effective, so we included a thorough health economic evaluation. Now, anyone who's trying to plan research, how do you pick your primary outcome? It's arbitrary, right? So we chose the Oswestry Disability Questionnaire because of the fact that it's been around for 40-odd years. It's been very well classified in terms of specificity and sensitivity for spinal outcomes. And plus, so many other people had used this in the past too. So this has a wealth of data and history behind it. So we chose that. And we chose it at 3 months because we wanted to make sure that we were getting patients treated quickly. We want patients to get back to work before they lose their jobs at 6 months. Obviously, we then followed that up with a whole batch of secondary outcomes, but you have to pick one outcome of which you power your study, right? So we chose Oswestry Disability, but obviously we then recorded all the other outcomes, including longer-term Oswestry Disability, VAS, the analog score of pain, the Rowland-Morris modified sciatica score, Likert economic analysis, and obviously COMI, because we like Spine Tango. So initially we thought we needed 200 patients. We assumed a 10% dropout. But then as we started to gather data and our theoretical values of ODQ that we'd put into the calculator at the start were then replaced by actual real values of numbers. So we were able to drop that down to 160, which was a big help. We powered it to 5% significance, and we wanted to detect a 10-point change, which we believe is the more widely quoted minimally clinical significant difference in ODQ. And we compared outcomes using a linear regression model. So we got funded in 2014. We started with a pilot between us and Salford. We needed to get over the threshold of recruiting 30 patients within 6 months, which we did. And then we opened it up nationally. So here's the results. We had to screen an awful lot of patients. And what we found pretty early on was that we needed to consent probably twice as many patients as we needed that would accept, because we were trying to sell apples and oranges to them. If you're trying to sell 2 treatments where we think we have equipoise, one is a very patient-friendly day case procedure with very perceived minimal risk. The other is an invasive surgical procedure. If you convey your equipoise to that patient, they're going to take the less risky treatment all the time, and that's what we found. So we needed to probably see a lot more patients than we could have done, because we were trying to sell 2 very different interventions. But we got roughly 83 surgery, 80 in the injection, so reasonable numbers and powered. Now look at the results. This is the demographic. I just want to draw your attention to the duration of symptoms. So in both groups, it was roughly about 21 weeks. It's a young person's problem look. So the mean age was 43 overall. And then look at this. This is the percentage occupancy of the canal by the disc. And so greater than 50%, these are what we all worry about as surgeons, isn't it? Are we going to miss a chord equina? There were very few, only 2 patients in the injection arm who had a big disc. So this is very much a lateral recess stenosis problem, not obviously a massive central disc problem. But all had radiological appearance of nerve root compression. So looking at the primary outcome at 18 weeks, here we are. This is the improvement in ODQ. So 24 points in the injection group, 26 points in the surgery group, and they weren't different. If you look at the histogram of the data to show the actual numbers of patients that improved, you can see these 2 curves pretty much overlap. So the changes in the Oswestry disability scores in terms of numbers of patients, here we've got purple showing the injection, the pink showing the discectomy. These 2 curves pretty much overlap. So if we estimated the effect of microdiscectomy versus an injection, we gained 4 points of ODQ by doing surgery, which we felt was not significant. In fact, it wasn't. So then looking at secondary outcomes, this was not just a flash in the pan, it was a maintained improvement in scores that was maintained up to week 54. What we did find, though, when we looked at the regression analysis, that there was a clear factor of time in surgical in the improvement of pain and outcomes. So there was a clear effect of this, and we know this is true, that the discs do improve and heal themselves over time, and that was very clear from this data. The same thing was mirrored in VAS leg pain. So we saw a sustained result, a short-term improvement followed by a maintained long-term improvement, such that by week 54, there was a regression to the mean where there was a clear reversion to normality. Back pain, again, we say we don't treat back pain with discectomy, but clearly we do, because we can get over 20 points of back pain improvement, either with an injection or with surgery. So That just shows you how complicated this topic is. Modified Rowland-Morris, same thing. We found the same result, no difference between the two treatments. Now, okay, so looking at type of disc prolapse, well, we probably missed a trick here because we didn't use a radiological assessment for this. We just used a surgical direct observation. So we asked the surgeons who were doing the surgery what type of disc they encountered at operation. 72% it was a contained disc, i.e. the annulus was, part of the annulus was over the disc and there was no extruded fragment, and then 38% extruded or sequestrated. But if you did an analysis between whether the type of disc made a difference, no, it didn't. Complications here was the big surprise. So we had 4 serious adverse events in the surgery group and none in the injection group. And one of those SAEs was a nerve root lesion, a weakness. Now, that happened in our center. I can tell you the nerve root wasn't actually damaged, but the patient woke up with a foot drop and it hadn't recovered. So, you know, it wasn't the case of the nerve root being cut inadvertently, but things happen. So that's the thing. And what we can say from this is unbiased reporting. So this is honest and, you know, not reported by surgeons, but it's reported by the strict layers of research governance that go in with a trial like this. But in the injection group, no serious adverse events. Looking at health economics very quickly, we want to have some questions. If we took microdiscectomy compared to an injection, then you were basically paying £38,000 per quality adjusted life year to get the same clinical benefit. So the probability of this being cost effective isn't there, right? So basically we take 20K as a cutoff for a cost effective treatment. So to get the same quality improvement with surgery first, it costs you just under £40,000. So therefore to do the surgery first is not effective, not cost effective. So do the injection first. So in summary then, for non-cauda foot drop cases, i.e. for the majority of sciatica patients that we see, we achieved the minimal clinical difference in the ODQ in 72% with an injection, 72% with surgery and 68% with an injection, so very similar numbers. So roughly 2/3. If you look at the patients who actually went on to have surgery, it was only half. So this trial avoided surgery in about half the patients, so Butterman was right. However, the complications are far more serious from surgery, and it's certainly not cost-effective in treating patients with surgery first. So we would recommend, those of you that have been doing this decades ago already, stick with that plan. Patients who come in with a non-foot drop, non-cauda equina disc, it's safe to do an injection. You'll avoid surgery in half of them. I can tell you the post-COVID surgical data from our unit is that we have actually halved the number of discectomies now that we've got back going again since pre-COVID. So we have changed. Future work, we want to extend it beyond 1 year. We want to try and galvanize a treatment pathway for sciatica, as there still exists quite big variation throughout the UK for patients, and it depends on your postcode how you get treated and where you are. And we really want to get that treatment time down for patients and get them back to work as soon as possible. That's it. These are the acknowledgements. This is not an individual process. There are, this is a lot of acknowledgements here. It's a big piece of work, and I'd like to thank everybody on this list. And I'd like to thank you all for listening.
Thank you very much. So we've probably got time for 1 or 2 quick questions, please. Yes, sir, go ahead.
Tony Rees from Glasgow. Can I ask Martin, this is going to sound like a daft question. When you did the injections, and say you were dealing with a level 4-5 pathology, which level did you inject? Did you inject the 4-5 level, where the actual disc pathology was, or did you inject the level below, where the nerve root, the L5 nerve root, comes out of the foramen?
Yeah, so this was so for L4-5, it would be the foraminal to allow for that run down into the lateral recess. Now, this was a pragmatic study, right? So we allowed a lot of independent interpretation. What we wanted was your local treatment policy of a nerve root injection. We stipulated only a few things. It had to include anesthetic. It had to include some steroid. We recommended which steroid to use. You also had to use contrast to make sure that you hadn't inadvertently hit a radicular artery. But apart from that, we accepted all comers. So as long as you used X-rays or CT, so some form of radiological intervention, it didn't matter. As long as you were getting your contrast spread down the nerve root in question, however you got there, either at the foramen or above it or below it. But generally speaking, you injected it at the disc that was involved.
Okay, second question, if I may.
Yep.
In the group that had the injection who then required surgery, was there
Yep.
any difference in their results compared to the ones that had surgery
Not
first
that we
off? that you
found,
know?
no. Not that we found.
Okay, thank you.
Christine?
Thank you very much.
Thank you.
Really interesting talks, both of you. So I've got kind of a combined question for both of you. So Martin, I noticed that within your data, there's very large standard deviations. So have you looked at kind of the scatter plots of the patient information to see, are there kind of responders and non-responders? So do you have ones that actually get worse and rather than better? And are there any of the measures that can help predict which ones are responders and which ones aren't, to try and dissect that out a little bit and stratify the patients? And I'm really interested with the imaging that you showed, Annika, in terms of, you know, and is that kind of widely available? So could that be something that could be used clinically?
I'll go first. No, we haven't done that. But certainly that's something we'd like to do.
In terms of the imaging, so diffusion imaging is sometimes done, especially for brachial plexus injuries. These images can be done on a normal 3 Tesla scanner for the lumbar spine. 1.5 will be pushing it for the lumbar spine. But it can be done on a normal clinical scanner. The tricky bit is a bit the post-processing, which at the moment to get good quality data is still quite labor intense. And there is quite a lot of efforts underway at the moment to automate that more. Yeah, so I believe it's probably a matter of time, and it will be able to be done quite as a standard sequence. It's not even that long. It's about 10 minutes for that. So it's not like excessive. Yeah.
Thank you. Quick question, Ashley.
Question for Martin. Congratulations on the trial. I know you put a lot of work into that. For the primary outcome at 3 months, what was the time between the injection and the 3-month outcome, and the surgery and the 3-month outcome? Because your baseline would be randomization.
Yeah, no, you hit a really good point there. So the clock started at randomization, and we really tried to get treatment delivered within 6 weeks of randomization. So, but again, there were some that were closer to the end, but they were the minority, so the vast majority were within the 6 weeks. But that's the best we can tidy it up.
I'm afraid we'll have to call today. Round of applause for both of our speakers, please. Thank you.